4, 3, 2, 1. Disclaimer. I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. I will go through the videos fairly quickly as they are available on the Cornell website and most of the diseases are fairly common. Case example 10-1 Signalment. 8-year-old spayed female boxer. Brittany chief complaint. Inability to use the pelvic limbs history. The day before this video recording was made, the owner left her home at 11 a.m., leaving Brittany in the house. On returning at 3 p.m., she found Brittany unable to stand on her pelvic limbs. Examination. Video 10-1 shows the flaccid paraplegia and the hyperextended thoracic limbs but normal voluntary use of these thoracic limbs. Note the atonia and areflexia in the left pelvic limb and the mild hypotonia and hyporeflexia in the right pelvic limb. Note the analgesia of the left pelvic limb except for the proximal medial thigh area. Not shown are the normal tail and anal tone and perineal reflex. Anatomic diagnosis. L4 to S1 spinal cord segments. Worse on the left side, less likely the L4. S1 spinal roots or nerves are both femoral and sciatic nerves bilaterally. The thoracic limbs exhibit Schiff-Sherrington syndrome resulting from the sudden loss of function of the lumbar spinal cord neuronal cell bodies of the long interneurons that normally inhibit thoracic limb extensor motor neurons. However, the pelvic limb's clinical signs are not caused by spinal shock because they are so asymmetric, and the left pelvic limb areflexia had persisted for 24 hours when this examination was done. The intact nociception from the proxima medial thigh area indicates sparing of the genitofemoral nerve, which arises from the L3 and L4 spinal cord segments. The right pelvic limb paralysis represents a mixture of loss of function of the UMN and GP systems in the white matter and mild loss of GSELMN function, all of which can occur in these segments. Differential diagnosis. Fibrocartilaginous embolic myelopathy, FCEM, intervertebral disc extrusion. Neoplasia external injury was excluded by the history. On the basis of the acute onset of clinical signs and the signalment, FCEM and intervertebral disc extrusion are the two most likely presumptive diagnoses. The absence of any discomfort is more likely with FCEM, but exceptions are common. It is important to make this distinction in the clinical diagnosis because an extruded intervertebral disc commonly requires immediate surgery. Ancillary procedures. Radiographs of the lumbar and sacral vertebrae were normal. Myelography and computed tomography, CT, plus myelography, see video 10-1, were performed and showed a mild intramedullary swelling of the lumbosacral intumescence. The CT images are from the body of the L3 vertebra through the body of the L5 vertebra. Because of the guarded prognosis, Brittany's owner requested euthanasia. Autopsy confirmed extensive infarction scattered through the caudal lumbar and cranial sacral spinal cord segments. Gray matter was more extensively affected on the left side. Numerous fibrocartilaginous emboli were found in spinal cord blood vessels associated with these lesions. Fibrocartilaginous embolic myelopathy FCEM is a spinal cord lesion that is common in dogs but is uncommon in other species of domestic animals. It is most common in young adult dogs of the larger breeds, but it may occur as young as 3 months of age and is common in the miniature Schnauzer, Labrador Retriever, and Boxer breeds. In our experience, the clinical signs are peracute in onset, often occurring while the dog is physically active and usually stabilizing within 24 hours. Rarely, clinical signs may progress for 48 hours. Following that, no further progression is seen or improvement occurs, depending on the degree of ischemia or infarction. Importantly, the dog may appear in significant discomfort at the onset of the neurologic deficit and may cry out. This often resolves in a few hours as the neurologic deficit becomes maximal. Rarely, we have seen dogs with FCEM act painful for several days. The lack of persistent discomfort in the setting of a peracute to acute onset of signs often helps prioritize FCEM on our differential diagnosis. Central neurogenic pain refers to spontaneous pain associated with CNS parenchymal lesions that do not involve the meninges. Acute spinal cord injury or ischemia may be related to spontaneous pain in addition to some loss of sensory function caudal to the lesion. The extreme discomfort exhibited by some dogs at the onset of spinal cord ischemia associated with fibrocartilaginous embolism may well be an example of spontaneous central neurogenic pain. The pathophysiology of this form of pain is poorly understood, but disinhibition of dorsal gray column neuronal cell bodies that project into the spinothalamic pathway or a disturbance of the lateral spinothalamic tract, the ventral spinothalamic tract, or both, which results in spontaneous discharge, are possible explanations. The source of the fibrocartilage is assumed to be the intervertebral disc that is undergoing degeneration. This embolic fibrocartilage has the same collagen type that is found in the nucleus pulposus. How this degenerate fibrocartilage gains access to the spinal cord vasculature is still speculated. These emboli are more common in small arteries but also may be found in veins. Arteriovenous anastomosis occur in the blood supply of the spinal cord and have been implicated in the distribution of the emboli. Protrusion of degenerate intervertebral disc material into the adjacent ventral internal vertebral venous plexus has occasionally been observed at autopsy. It has been suggested that the normally avascular intervertebral disc is invaded by new growth of arteries when degeneration occurs in the annulus fibrosus and that this is a route for these emboli to enter the arterial vasculature. We find this mechanism difficult to accept. In humans, degenerate intervertebral disc material may protrude into the adjacent vertebral body, where ready access to the blood vessels exists in the marrow of the vertebra. One route of venous drainage from this marrow is into the ventral internal vertebral venous plexus within the vertebral canal. These intramedullary protrusions are referred to as Schorl nodes. They are rare, or at least rarely identified, in dogs, which may be because of dogs' quadruped posture and the thick layer of cortical bone that is adjacent to the intervertebral disc. Reverse venous blood flow may be involved in the distribution of these emboli. Whenever an animal strains by contracting its trunk muscles with the glottis closed, the increased pressure in the thorax and abdomen interferes with the venous return to the heart and forces the venous blood into the vertebral venous plexus. This is the Valsalva maneuver, and it may play a role in the ability of these emboli to gain access to the spinal cord vasculature. The involvement of the intervertebral disc as the source of these emboli is also supported by the observation that these lesions occur primarily in the spinal cord. One report of brainstem lesions with fibrocartilaginous emboli indicated a possible source of emboli from cervical intervertebral discs. Magnetic resonance imaging, MRI, often shows a region of the spinal cord that is swollen and hyperintense on T2-weighted, T2W, images suggestive of edema. Additionally, often in situ degeneration of the nucleus pulposus is evidenced by a loss of the hyperintense signal on T2W images at the level of the FCEM lesion in the spinal cord. These FCEM lesions may be unilateral or bilateral at any level of the spinal cord, and they affect various combinations of gray and white matter. The lesions are usually limited to a few adjacent spinal cord segments. Many of the following case examples involve various regions of the spinal cord. Caudal brainstem signs are rare and probably are associated with emboli arising from the cervical intervertebral discs. Because of the extensive collateral circulation to the spinal cord, figure 10-1 10-4. Multiple blood vessels must be compromised to cause a degree of infarction and severe clinical signs seen in dogs similar to Brittany. This suggests that a sudden shower of emboli must occur at one time. At autopsy, these emboli may be found in many blood vessels in or near the lesions. These are more common in the meningeal vessels than in those within the affected parenchyma, but they may be found in both sites. Usually, this shower affects the blood vessels to a few adjacent spinal cord segments, and the associated lesions often are scattered and asymmetric within these segments. Thus, the clinical signs are usually focal and often asymmetric, as seen in Brittany. FCEM may be much more common than we realize and not be extensive enough to cause clinical signs or cause only transient clinical signs. Most veterinarians have had the experience of being called by a distraught owner who has just found the pet dog collapsed and unable to stand, but by the time the dog arrives at the hospital for examination, it is walking normally. We believe that some of these transient episodes of collapse may arise from transient spinal cord ischemia caused by FCEM. I, e.g., have recently had the chance to not only examine but also witness a 14-month-old boxer that was playing ball with its owner in the street near my home when the dog suddenly screamed at and began dragging both pelvic limbs. This occurred right in front of me. The dog's blood-curdling scream lasted 10 to 15 seconds. Within a matter of 30 to 60 seconds of the onset of paraplegia, the right pelvic limb began functioning more normally. When I examined the dog within a few minutes, the left pelvic limb now only had mild antheresis and GP ataxia, and the dog was no longer in pain. Both patellar reflexes were brisk. Within 10 to 15 minutes, the dog was completely normal and running around again, with no ill effect. I assumed the cause to be FCEM of one or more segments from T3 to L3. The owner, a neighbor of mine, was extremely relieved by the dramatic and rapid improvement. Although this event was scary for the owner, witnessing it unfold right before my eyes was a fortuitous experience for me as a neurologist. Many dogs in which you make this clinical diagnosis will recover spontaneously. This is more common in dogs with paresis and ataxia caused by interruption of the UMN and GP pathways. The more severe the involvement of the gray matter in the intumescences, the more guarded is the prognosis. As a rule of thumb, if no signs of improvement are seen in 10 to 14 days after the onset of clinical signs, it is unlikely that any recovery will occur. In a few patients, after an initial mild improvement, a period of weeks may pass before the animals rapidly regain the ability to walk. We usually tell owners that it may take up to 10 weeks before complete recovery is seen. An interesting observation is that FCEM is very rare in the chondrodystrophic breeds in which the chondroid metaplastic form of intervertebral disc degeneration is very common. FCEM also is observed in dogs as young as 3 months of age, in which you do not expect intervertebral disc degeneration to occur. In these young dogs, the source of cartilage may be the vertebral growth plates. Often, an associated history of mild trauma, for example, a sudden fall or vigorous playing and jumping as with catching a frisbee, may be present. This relationship between young age and vigorous handling is associated with FCEM in young feeder pigs. It occurs during their transport to shine in crowded trucks. The three primary disorders that may cause an acute onset of relatively non-progressive spinal cord dysfunction are external injury by objects in the environment, most commonly motor vehicles, internal injury resulting from intervertebral disc extrusions, and vascular compromise resulting from FCEM. The history usually permits substantiation or exclusion of external injury. In the absence of history, radiography of the vertebral column should provide that answer. To differentiate between the other two causes of these clinical signs, evidence of continued discomfort by the patient is more suggestive of an intervertebral disc extrusion than of FCEM, but exceptions are common for both of these disorders. Ultimately, immediate imaging is necessary because a diagnosis of an intervertebral disc extrusion usually requires emergency surgery. MRI is the most reliable imaging modality in detecting the spinal cord edema that accompanies the ischemia or infarction caused by the fibrocartilaginous emboli. Be aware that MRI that is done in the first 24 to 48 hours after the embolic shower occurs may occasionally be normal. Additionally, MRI is supportive but not diagnostic of FCEM. Swelling and edema of the spinal cord are not unique to FCEM. However, for the clinician, MRI is the most conclusive means of differentiating non-surgical disorders from those that benefit from surgery. For example, acute intervertebral disc herniation. Myelography in dogs with FCEM is helpful only in the small percentage of dogs in which intramedullary swelling is extensive. However, in most cases of FCEM, myelography is normal. From a practical standpoint, normal myelography, as with MRI, helps exclude from consideration a compressive lesion that may benefit from surgery. Signalment. 3-year-old female Labrador Retriever, Brandy. Chief complaint, inability to stand on the pelvic limbs. History. The owner observed in Brandy, who was an indoor dog, a sudden loss of the ability to walk with the left pelvic limb, followed in a few hours by collapse of the right pelvic limb. Examination. Video 10-2 was made 12 hours after the onset of the pelvic limb dysfunction. Note the paraplegia with thoracic limb hyperextension but normal voluntary movements in the thoracic limbs, the pronounced pelvic limb hypotonia but intact spinal reflexes, and the line of analgesia at about the thoracolumbar junction. Anatomic diagnosis. Focal caudal thoracic transverse spinal cord lesion with Schiff-Sherrington syndrome in the thoracic limbs and spinal shock in the pelvic limbs. Differential diagnosis. FCEM, intervertebral disc extrusion, neoplasia, external trauma. The history of this dog's clinical signs given by its owner is sufficient to rule out any external injury. It was difficult to determine how much of this dog's struggling was from discomfort, frustration, or dislike of the examiners. An acute intervertebral disc extrusion is less likely than FCEM in a 3-year-old Labrador Retriever because of his young age. No ancillary studies were performed in Brandy, and with no clinical signs of improvement after a few days, the owners elected euthanasia. Autopsy revealed extensive ischemic and hemorrhagic infarction in the caudal thoracic spinal cord segments, with numerous fibrocartilaginous emboli in both arteries and veins. No intervertebral disc material was found on opening the ventral internal vertebral venous plexus in the area of the involved spinal cord segments, and a median plane section of the vertebral column did not reveal any recognizable intervertebral disc material in the marrow of the vertebral bodies. The following videos show 2 more examples of the Schiff-Sherrington syndrome. Video 10-3 shows Spanky, an 11-year-old male mixed breed dog that was riding in a car that skidded on ice and struck a guardrail. Radiographs, shown at the end of the video, revealed a fracture in the spinous process of the T6 vertebra and a collapsed intervertebral disc space that is wedge-shaped between the T5 and T6 vertebrae, with no displacement. The wedge-shaped collapsed disc space is a subtle finding but highlights the need to carefully scrutinize radiographs in animals with a history of external trauma. The video was made 4 days after the injury. Note the pelvic limb hypertonia and hyperreflexia and therefore no evidence of any spinal shock. Note the presence of nociception in the pelvic limbs, indicating that the spinal cord lesion has not caused a complete transverse dysfunction. A buddy cast was applied, and Spanky regained the ability to walk with his pelvic limbs in about 5 weeks. Video 10-4 shows a 6-year-old Parson, Jack, Russell Terrier that had been struck by an automobile and suffered a moderately displaced fracture of the L3 vertebra and subluxation of the L3, L4 disc space. The video shows the radiographs. Note the clinical signs of Schiff-Sherrington syndrome but the absence of any spinal shock. In our experience, Schiff-Sherrington syndrome and spinal shock are rare in cats. The following 3 videos show cats with thoracolumbar vertebral column fractures that caused a transverse spinal cord dysfunction with peracute paraplegia and analgesia caudal to the lesion. None shows evidence of Schiff-Sherrington syndrome or spinal shock. Video 10-5 shows Poison, an 8-year-old castrated male domestic short-hair cat that was struck by a motor vehicle 2 days before the video was made. Note the crossed extension in the pelvic limbs and the pelvic limb flexion when the tail was compressed with forceps. The latter is referred to as a mass reflex, which is another manifestation of hyperreflexia. Radiographs, see the video, showed a subluxation at the articulation between the L3 and L4 vertebrae, with at least 50% displacement. Poison was euthanized, and the autopsy showed that only a sleeve of dura remained at the site of the subluxation. The parenchyma of the spinal cord at this site had been completely crushed and displaced into the adjacent spinal cord segments. Figure 10-5. Video 10-6 shows George, an adult Siamese cat that was found beside the road unable to use his pelvic limbs. Radiographs, see the video, showed a subluxation at the articulation between the T13 and L1 vertebrae. Note the pelvic limb flexion when the tail was compressed with forceps. This is an example of a mass reflex. George was euthanized, and autopsy revealed hemorrhage and necrosis that involved all of the transverse section of the spinal cord at the level of the fracture. Figure 10-6. The spinal cord lesions resulting from injury caused by external trauma include the physical disruption of the high-risk spinal cord parenchyma compared with the more resistant oral layer of meninges. Figure 10-6 shows this severe spinal cord lesion. A contused spinal cord exhibits hemorrhage, edema, and necrosis caused by compromise of the spinal cord's vasculature. Following the traumatic event, degeneration of the injured spinal cord continues and progresses for a few hours, usually less than 24 hours. The basis for this is the subject of intense research directed at determining ways to treat these patients to prevent this progressive spinal cord destruction. Areas of interest include the release of neurotransmitters such as toxic levels of glutamate, excessive accumulation of calcium ions, free radical species, nitrous oxide, and the release of various amines that cause vasoconstriction and subsequent ischemia and infarction. Video 10-7 shows an 8-week-old Siamese kitten that was found beside the road by employees of the Society for the Prevention of Cruelty to Animals. Radiographs, see the video, showed a fracture at the T8, T9 vertebral articulation, with complete displacement through the vertebral canal. The kitten's owner could not be found. Despite the peracute paraplegia and analgesia caudal to the lesion, no signs of the Schiff-Sherrington syndrome or spinal shock were evident. An internal medicine resident adopted the kitten in spite of knowing that the clinical signs would not improve. The fracture was reduced and stabilized, and a cot was made for the kitten. See the video. The resident later took a permanent position in Alaska, and the then young adult cat was still doing fine and enjoying life in a larger cart. pelvic limb monoplegia, UMN. Case example 10-3 Signalment. 3-year-old castrated male Malamute. Drake chief complaint. Inability to use the left pelvic limb history. After a 5-mile run with his owners, Drake was in their home when he suddenly lost the ability to move his left pelvic limb. He was examined by a local veterinarian and then referred to Cornell University, where his disorder was filmed on the second day of the dysfunction, which had not changed since the onset. Examination. Video 10-8 shows the spastic monoplegia limited to the left pelvic limb. The right pelvic limb gait was mildly paretic, and ataxic, and the limb showed some difficulty with the hopping response. Anatomic diagnosis. A focal lesion on the left side, between the T3 and L3 spinal cord segments. Do not confuse this anatomic diagnosis with sciatic nerve paralysis, which looks much different. Review video 5-46 of the collie dog Keen, described with case example 5-15. Keen has a left sciatic nerve injury from a pelvic fracture. Dogs with sciatic nerve deficits may always advance the limb by hip flexion, and hypotonia of the crural muscles is present. Differential diagnosis. FCEM, intervertebral disc extrusion. Neoplasia external injury was excluded based on the history and on the knowledge that such localized unilateral signs would be very unusual for an external spinal cord injury. The lack of any discomfort following the onset of the paralysis or during the examination is more subtype of FCEM than of an intervertebral disc extrusion. An intervertebral disc extrusion would be unlikely in a 3-year-old non-chondrodystrophic breed. However, it is best ruled out by imaging. Radiography and myelography were normal, which supported a presumptive FCEM lesion. On the video, you can follow the spontaneous recovery. The section of the video where Drake is walking indoors after you see his vigorous response to a noxious stimulus was made 1 week later, and the section outdoors was made 3 weeks after the initial filming. Signalment. A 6-year-old castrated male Labrador Retriever. Penfield chief complaint. Inability to use the right pelvic limb history. The owners were playing ball with Penfield in a local park when he suddenly yelped and stopped using his right pelvic limb. Examination. This examination took place the day after the onset of the clinical signs, which had not changed. Video 10-9 shows that this dog's clinical signs are the mirror image of those observed in Drake in case example 10-3. Penfield exhibits a spastic monoplegia of his right pelvic limb. Anatomic diagnosis. Focal lesion on the right side of the spinal cord between the T3 and L3 spinal cord segments. Differential diagnosis. The diagnosis is the same as that described for Drake in case example 10-3. The indication of discomfort when the initial clinical signs occurred is suggestive of a possible intervertebral disc extrusion or FCEM. Radiography and myelography help diagnose a unilateral right side intervertebral disc extrusion between the L3 and L4 vertebrae. This was removed via a hemilaminectomy, and Penfield was walking with the right pelvic limb after about 3 weeks. The following 2 videos show the same 2 clinical disorders that are described in this case example 10-3. Video 10-10 shows Dude, a 3-year-old male miniature schnauzer that had been outdoors unconfined during the night and was found in the morning unable to use his left pelvic limb. From your study of this video you should make the anatomic diagnosis of a focal spinal cord lesion on the left side between the T3 and L3 spinal cord segments. The differential diagnosis is the same as in this case example 10-4 and case example 10-3 but must include external injury because the history cannot rule it out. The absence of any reluctance to try to walk as well as of any discomfort when palpated in the presence of extensive unilateral signs all suggest that external injury is unlikely. The young age of this dog suggests that a unilateral intervertebral disc extrusion is also less likely. In addition, this breed is at some risk for the development of fibrocartilaginous emboli. Radiography and myelography were normal, which made FCEM the most presumptive diagnosis. Within 2 to 3 weeks, without specific therapy, Dude was walking well in the left pelvic limb. Figure 10-7 shows the kind of FCEM lesion that explains these clinical signs but from which recovery would not occur. Video 10-11 shows Beaver Dam, an 8-year-old spayed female mixed breed dog that was presented because of difficulty using the left pelvic limb. This dysfunction began when the dog fell down a flight of stairs and had not changed significantly since that time. From your study of the video, you should make the same anatomic and differential diagnosis as for Dude in the previous video. The video of Beaver Dam shows images from radiography, myelography, and CT, which help diagnose intervertebral disc extrusions at the L1, L2 and L3, L4 vertebral articulations. The owner elected to treat the dog medically, and no follow-up information on the success of this treatment is available. Paraparesis and pelvic limb ataxia, UMN, GP. Case example 10-5 Signalment. 5-month-old male Labrador Retriever, Cassidy chief complaint. Inability to walk normally with the pelvic limbs history. About 4 weeks before examination at Cornell University. This dog was on a camping trip in the Adirondacks when the owners first noticed that Cassidy occasionally stumbled with his left pelvic limb. Within the next week, he was also stumbling with the right pelvic limb. This pelvic limb dysfunction slowly progressed until the time of this examination. Video 10-12 shows the monoplegia of the left pelvic limb and grade 2 monoparesis and ataxia of the right pelvic limb, with absent postural reactions. Cranial nerves and thoracic limb function were all normal. Note the mild hypertonia and normal spinal reflexes for the pelvic limbs and the normal nociception. infection. Anatomic diagnosis. A focal or diffuse lesion between spinal cord segments T3 and L3. Worse on the left side with normal nociception. No reliable way exists to localize a focal lesion between these segments using a physical neurologic examination. Be aware that multiple or diffuse lesions in this anatomic area would be indistinguishable from a single focal lesion based on your examination. This would explain the clinical signs that were observed in this dog. Differential diagnosis. The following diagnoses are limited to those spinal cord disorders that could cause a progressive lesion within these thoracolumbar spinal cord segments of a dog. Neoplasm, vertebral malformation, myelitis, disc spondylitis, multiple cartilaginous exostosis, intervertebral disc extrusion protrusion, degenerative myelopathy, nephroblastoma. Although we tend to relegate neoplasia to older dogs, many exceptions to this exist, and one of them occurs at this location in dogs. Nephroblastoma is a unique intradural, extraparenchymal neoplasm that occurs in young dogs, usually between spinal cord segments T10 and L2, figures 10-8 through 10-11. Most of our experience and reports in the literature involve dogs younger than 3.5 years of age, many of them only a few months old. Numerous reports have been published, mostly in the European literature, describing this neoplasm as an ependymoma. In the first two editions of this text, IAD recognized that this was not intraparenchymal and therefore was not an ependymoma, and I called it a neuroepithelioma based on the morphology of the cells and the abundance of tubular epithelial elements in the neoplasm. Since then, we have recognized tubular structures that resemble renal glomeruli and have diagnosed this neoplasm as a presumptive nephroblastoma. It is an embryonic neoplasm that may arise from mesonephric tubules. This is supported by the positive immunocytochemical staining of the neoplastic cells for a polyglycolic acid marker of this tumor. This test was developed in children by Dr. Roth in Switzerland. In children, this nephroblastoma occurs in the kidney and is called a Wilm tumor. A gene located on chromosome 11 has been identified for this tumor in children. Using antibodies developed for the protein product of this tumor gene, immunocytochemical staining has identified this protein product in the canine neoplasm. The unique location of this neoplasm between spinal cord segments T10 and L2 correlates with the site of embryonic renal development from intermediate mesoderm. This is adjacent to the development of the somatic scleroderms that envelope the neural tube that forms the thoracolumbar spinal cord. A Wilm tumor has three components. 1. Sheets of unorganized epithelial cells referred to as blastomal cells. 2. Tubular elements lined by epithelial cells that vary from squamous to cuboidal and some of which form glomerular structures. And 3. A fibrous component that consists primarily of bundles of collagen. The canine neoplasm is made up primarily of the first two components. Figures 10-12 through 10-15. An nephroblastoma in this spinal cord location is very rare in children. In dogs, this neoplasm does occur in the kidney, but it is much more common adjacent to the spinal cord. This neoplasm has not been reported to occur in both locations in the same patient. Typically, the clinical signs occur in one pelvic limb prior to their occurrence in the other, which reflects the asymmetric location of the neoplasm and makes sense from an embryologic standpoint. On contrast MRI, this neoplasm is uniformly enhanced. We suspect this is a very slow-growing neoplasm and recognize that the spinal cord may be slowly compressed by an extraparenchymal mass for a long time before the autoregulation of spinal cord vascular perfusion fails and clinical signs occur. Therefore, when these clinical signs occur, be aware that the spinal cord is already very compressed, and if surgery is to be considered, it should be done as soon as possible. Often, at autopsy and even at surgery, the spinal cord consists only of a thin 1 to 3 mm quarter moon-shaped shell covering one side of the neoplasm. See figures 10-10 through 10-12. When surgeons remove this neoplasm, they often see the severely compressed spinal cord slowly starting to fill the space from where the mass was removed. Postoperative radiation therapy should be considered to help avoid recurrence of the neoplasm. Another neoplasm that is more common in cats and may occur at any level of the vertebral canal is lymphoma. In cats, it commonly occurs before 1 year of age. Some of these cats will also be positive for feline leukemia virus, FeLV, infection. Gliomas are less common in the spinal cord of all species and usually occur in older animals. Vertebral malformation with kyphosis and secondary spinal cord compression is a realistic consideration in this dog. This malformation is relatively common in the French and English bulldogs, or any of the brachycephalic breeds with screw-shaped tails, but may occur sporadically in any breed. This vertebral malformation is usually in the mid-thoracic portion of the vertebral column. Although these dogs have the vertebral malformation at birth, the clinical signs of spinal cord compression usually do not occur until a few months of age but prior to 1 year of age. We believe that the kyphosis that causes the spinal cord compression develops at the site of the malformation as the dog grows, and this accounts for the delayed age of onset of the progressive spastic paraparesis and ataxia of the pelvic limbs. In some dogs, radiography performed over a period may disclose greater degrees of kyphosis. Occasionally, on your physical examination of the patient, you can see and palpate the kyphosis. However, it is easy to overlook if you do not take the time to carefully examine the patient for it. This malformation is readily seen on radiographs. It was not visible or palpated in cavity. See videos 10-15 and 10-16. Myelitis must be a consideration in any patient with progressive spinal cord clinical signs and especially in a young animal. The most common is myelitis caused by the canine distemper virus. Other infectious diseases are caused by the protozoal agents, Toxoplasma gondii, Neospora caninum, Rickettsia species, and fungal agents. Granulomatous meningoencephalomyelitis is a presumed non-infectious disorder that may have a lymphoproliferative basis or possibly autoimmunity. It is rarely limited to a focal lesion in the spinal cord. As a rule, these infectious agents cause multifocal lesions, and you should expect that after 4 weeks of progressive thoracolumbar clinical signs, some clinical indication of lesions would be evident elsewhere in the CNS. Although these infectious agents may also affect other organ systems, the CNS may be the only system affected. Serology, polymerase chain reaction, PCR, testing, and evaluation of cerebrospinal fluid, CSF, may be of value in making this diagnosis. Other infectious agents may be more common in different geographic locations. Disc spondylitis, also known as intradiscal osteomyelitis, is usually caused by a bacterial or fungal agent. Staphylococcus pseudointermedius is the most common isolate. Streptococcus species and Escherichia coli have also been isolated in this lesion. Be aware that particularly in intact male dogs, Brucella canis has been identified in these infections and that it is contagious to humans. Although this is more common in the southern states, e.g., have seen a Brucella canis disc spondylitis case from Staten Island, in New York State, with no associated history of travel. Therefore, all cases of disc spondylitis should be tested for B. canis given the zoonotic potential. In German Shepherd dogs, especially young dogs, or those not responding to antibiotic therapy, fungal infections should be especially considered. The Ariel breed may be predisposed to disc spondylitis, as determined by a study of a kennel of Airedales with disc spondylitis spondylitis that revealed the low serum immunoglobulin A, IgA, high serum B1 globulins, and blastogenesis suppressing factors. The encroachment of this expanding infection into the vertebral canal may compress the spinal cord, or compression may follow the vertebral instability caused by the infection. Most vertebral column infections are hematogenous, but the source is rarely identified. A migrating planton can also be the source of this lesion, as bacterial endocarditis may underlie some infections. Affected dogs should be carefully auscultated for a murmur. We recently have studied a case of discus spondylitis presumed secondary to salmonella infection in a dog that had been fed a raw diet contaminated by salmonella. The incidence is higher in male dogs, and the incidence in both sexes increases with advancing age. As a rule, these infected vertebrae cause a great deal of discomfort for the patient, and this is obvious when you palpate the vertebral column. Although many of these dogs are depressed, have a fever, and exhibit clinicopathologic changes suggestive of an infection, exceptions to this are common. Cassidy had no systemic signs of an infection and exhibited no discomfort when the vertebral column was vigorously palpated. Any of the imaging procedures, radiography, CT, MRI, are useful in making this diagnosis. Be aware that the radiographic changes may lag behind the onset of clinical signs. Multiple cartilaginous exostosis. Multiple cartilaginous exostosis is an uncommon disorder of young animals that occasionally involves the spinal cord. These exostoses are benign proliferations of cartilage and bone associated with growth plates. They grow by endochondral ossification similar to that of physiocartilage. These growths are covered by hyaline cartilage and are common in long bones, ribs, and vertebrae. They form large, easily palpable masses at these sites. Those that develop along the vertebral column may invade the vertebral canal and cause an extradural spinal cord compression. These growths are more common in the thoracolumbar vertebral column. As a rule, these exostoses stop growing as the normal growth plates stop their growth. However, in cats, these lesions tend to develop when they are skeletally mature. Occasionally, one of the lesions becomes neoplastic and continues to grow. If neurologic signs develop, it occurs prior to 1 year of age. These growths were not palpated in Cassidy. Intervertebral disc extrusion protrusion in this breed at this age would be very unlikely. Similarly, although the anatomic diagnosis in Cassidy is compatible with degenerative myelopathy, the age of onset is not. Most of these dogs are at least 5 years old and usually are older than 8 years. The progression of clinical signs is very slow, and a monoplegia or paraplegia would be very rare for this disorder in this short period. In addition, this degenerative disorder is rare in this breed. Although the age of onset is appropriate for an inherited degenerative CNS disorder, we are not aware that a disorder that would be compatible with this anatomic diagnosis has been reported in this breed. Nephroblastoma was the presumptive clinical diagnosis made for Cassidy. Radiography was normal, but myelography revealed an intradural extraparenchymal mass lesion at the level of the vertebral foramen of T13. The myelogram on the video clearly shows the cupping of the contrast as it tries to get by the mass lesion that is in the subarachnoid space. Although this neoplasm is surgically accessible, the duration and severity of the clinical signs indicate that the compression is very severe and the prognosis is guarded. The owner elected to have Cassidy euthanized, and an autopsy confirmed the diagnosis of a nephroblastoma. Video 10-13 shows another dog with a nephroblastoma. This is Caleb, a 6-month-old castrated male visual with a history of 10 days of rapidly progressive difficulty in the use of his pelvic limbs that started in the right pelvic limb. The video includes the myelogram that shows an intradural extraparenchymal mass at the level of the 13th thoracic vertebral foramen. The mass can be seen on the CT images made from the level of the intervertebral disc between the T12 and T13 vertebrae to the level of the intervertebral disc between the T13 and L1 vertebrae. The neoplasm was removed surgically, and significant improvement in the gait was observed by 1 week post-operatively. It is difficult for the surgeon to remove all of the neoplasm, and we have seen recurrence of the neoplasm occur within a 3-month period. We strongly recommend that this surgical site receive post-operative radiation therapy. 2 retrospective studies described the survival time in dogs undergoing surgical treatment for the removal of nephroblastomas. Interestingly, they provide mixed results. In one study, dogs undergoing surgery alone or in combination with radiation therapy, the median survival time was 374 days, which is similar to our experience with this tumor. Dogs with tumors that did not invade the spinal cord survived longer than those with intraparenchymal extension of the tumor, likely reflecting the ability to remove the tumor. In the second study, the median survival time of dogs treated surgically was only 70 days. Case example 10-6 signalment. 6-year-old Staffordshire Terrier, Sassy. Chief complaint, difficulty using the pelvic limbs. History. A week before examination at Cornell University, Sassy was examined by a local veterinarian for a sudden onset of abnormal use of the pelvic limbs, which slowly progressed during this 1-week interval. Examination. Video 10-14 shows the spastic paraparesis and the pelvic limb ataxia that is fairly symmetric. The pelvic limb hypertonia is severe. Despite being a very stoic dog, Sassy occasionally exhibited discomfort when the lumbar vertebrae were manually compressed. Anatomic diagnosis. Focal or diffuse spinal cord lesion between the T3 and L3 segments. Differential diagnosis. Intervertebral disc extrusion protrusion. Neoplasm. Discus spondylitis. FCEM. Myelitis. Degenerative myelopathy. Vertebral malformation. Intervertebral disc extrusion protrusion is the most presumptive diagnosis for Sassy. Neoplasm and discus spondylitis are the most important diagnoses to exclude. The sudden onset is less likely with degenerative myelopathy and vertebral malformation. Dogs with non-infectious myelitis may have a history of a rapid progression of clinical signs. Most vertebral malformations that compress the spinal cord result in clinical signs before 1 year of age. The lack of any other local sign of clinical signs does not favor myelitis. The sudden onset is compatible with FCEM but not with the history of progression of the clinical signs for 1 week. Degenerative myelopathy is a slowly progressive disorder and is uncommon in this breed. Imaging is necessary to differentiate among the first 3 differential diagnoses. Intervertebral disc extrusion protrusion. Intervertebral disc extrusion or protrusion occurs in all breeds of dogs but is most common in the chondrodystrophic breeds such as the Dachshund, Pekingese, French Bulldog, Basset Hound, Welsh Corgi, Beagle, and American Spaniel. Endochondral ossification is altered in these dog breeds and is sometimes referred to as hypochondroplasia. The chemical constituents of the nucleus pulposus of the intervertebral disc differ between the chondrodystrophic breeds and the non-chondrodystrophic breeds. This is the basis for the early onset of a chondroid form of metaplasia that occurs in the chondrodystrophic breeds. Hyaline cartilage replaces the nucleus, and further degeneration leads to calcification of the nucleus. These degenerative changes led to loss of the ability of the intervertebral disc to absorb the normal compressive pressures that occur in the vertebral column. The increased rigidity in the nucleus leads to tears in the annulus and extrusion of the degenerate nuclear material into the vertebral canal. Protrusions consist of proliferated annular fibers secondary to the degeneration of the nucleus and the chronic malarticulation that results between the vertebral bodies. This may be considered a form of degenerative joint disease, DJD, affecting a fibrocartilaginous joint. The metaplasia and degeneration in the chondrodystrophic breeds commences at a few months of age. The shock-absorbing function is compromised enough so that clinical disease related to acute extrusions or more chronic protrusions commonly occur by 2 to 3 years of age. In our experience, intervertebral disc extrusions are much more commonly associated with clinical signs than intervertebral disc protrusions in these breeds. Although not specifically classified as chondrodystrophic breeds, the following breeds are also commonly affected by intervertebral disc extrusion or protrusion at a relatively young age: Lhasa Apso, Shih Tzu, Miniature Doodle, and Cocker Spaniel. In the non-chondrodystrophic breeds, a fibrous form of metaplasia occurs, resulting in replacement of the nucleus with fibrocartilage. This starts at 4 to 5 years of age and slowly progresses as an aging process. Thus, clinical signs of intervertebral disc extrusion or protrusion in these breeds are usually related to an older age and are rarely seen before 4 to 5 years of age. A similar form of intervertebral disc degeneration occurs in cats as they age. Clinical signs of intervertebral disc extrusion or protrusion are relatively uncommon in cats and most commonly occur in the lumbar region of older cats. In 1952, H. J. Hansen described the pathology of intervertebral disc displacement, and since then, many veterinarians have referred to intervertebral disc extrusion as a Hansen type I disc and intervertebral disc protrusions as a Hansen type II disc. Most intervertebral disc extrusions are spontaneous and are not associated with any traumatic event. In dogs, about 80% of thoracolumbar extrusions or protrusions occur between the T10 and L3 vertebrae. This may relate to the increased motion of the vertebral column at this level compared with the more stable thoracic area. In addition, between the first 10 thoracic vertebrae, an intercapital ligament courses transversely across the dorsal surface of the intervertebral disc to connect the heads of the ribs where they articulate with both adjacent vertebrae. This is an added support to the articulation of the vertebral bodies and may help to prevent intervertebral disc extrusion or protrusion between thoracic vertebrae cranial to T10. These extrusions or protrusions produce varying degrees of compressive myelopathy and ischemia or infarction resulting from interference with the blood supply to the spinal cord. Sudden large extrusions cause acute injuries similar to those of an external traumatic event that fractures a vertebra, with hemorrhage, edema, and necrosis in both gray and white matter. It is very rare for the extruded material to enter the spinal cord. The only myelitis that may occur is the response to the tissue damage in the spinal cord. Inflammation may occur in the extruded degenerate intervertebral disc material and cause it to enlarge, which accounts for progressive clinical signs in some dogs. Recall that the nucleus pulposus develops from the notochord. As an avascular structure, it is immunoprivileged. With extrusions, the nucleus pulposus is exposed to the immune system and inflammation develops. At autopsy, small protrusions are commonly found that have not caused neurologic signs despite some that have caused mild spinal cord compression. Larger protrusions cause focal axonal degeneration and demyelination and progressive clinical signs. At surgery, hemorrhage from disruption of the ventral internal vertebral venous plexus may sometimes be seen mixed with the extruded intervertebral disc material. The hemorrhage is blue to black in color, with more viscous blood, and often creates a mass effect that suggests chronicity. This hemorrhage is also readily appreciated on MRI. A third type of presumptive intervertebral disc extrusion is recognized clinically and is best observed in MRI. A small percentage of dogs of any breed experience severe spinal cord trauma similar to that which follows external vehicular trauma but without the history. The patient has profound neurologic signs referable to the site of the spinal cord injury. On MRI, an obvious collapsed intervertebral disc space is evident, as well as focal changes within the spinal cord parenchyma overlying the collapsed intervertebral disc space but without significant compression resulting from the presumptive extruded intervertebral disc. Figures 10-16 and 10-17. A recent report was described this syndrome as an acute non-compressive nucleus pulposus extrusion. Clinicians refer to these as high-velocity disc extrusions, or a type 3 disc extrusion. Myelography reveals diffuse intraparenchymal swelling at these sites, which is associated with attenuation of the subarachnoid space. At surgery, the spinal cord appears edematous or slightly bruised. Minimal evidence of any extruded intervertebral disc material is seen in the extradural space. It is assumed that a small amount of intervertebral disc material has extruded dorsally against the spinal cord at a high velocity, causing severe contusion of the spinal cord without any obvious persistent compression. These observations need to be confirmed and explored further by autopsy study. Video May 10-3 represent a traumatic form of a type 3 intervertebral disc extrusion. Discomfort is the most common clinical sign observed with intervertebral disc extrusion or protrusion, followed by varying degrees of paraparesis and pelvic limb ataxia for thoracolumbar discs. The spinal cord and the intervertebral disc, beyond the periphery of the annulus fibrosus, have no axonal innervation. Therefore, the discomfort associated with intervertebral disc extrusion or protrusion is related to the disruption of the highly innervated periosteum or perichondrium associated with the vertebral column and the meninges associated with the spinal cord and the spinal nerves. The latter may be compressed by extrusions or protrusions that occur laterally into the intervertebral foramen. Paraplegia, with or without analgesia caudal to the spinal cord lesion, is the least common clinical presentation, and, in a very small percentage of these dogs, is associated with a progressive myelomalacia that was described in case example 5-14. The grading scheme for the degree of pelvic limb function that was previously described in this chapter was developed to follow the degree of recovery in these dogs using various medical and surgical techniques. Practitioners often use radiography as the first step in establishing a diagnosis of intervertebral disc extrusion protrusion. In our opinion, plain radiography has limited value in patients with a strong indication for intervertebral disc extrusion protrusion such as in a chondrodysplastic dog with an acute onset of signs referable to the T3, L3 spinal cord segments. The rationale being that radiography has very little utility in accurately diagnosing a specific site of intervertebral disc extrusion. For accurate interpretation, proper positioning is paramount and is difficult to accomplish in patients that struggle. Ultimately, radiography causes an additional cost to clients and is of limited benefit in establishing a definitive diagnosis in most animals. The main benefit of plain radiography is not in the diagnosis of intervertebral disc extrusion but in excluding other disorders more easily appreciated with plain radiography such as discus spondylitis, external trauma trauma, or neoplastic disease resulting in bony lysis. Therefore, careful patient selection is important when considering plain radiography. When the decision is made to perform radiography, be certain to radiograph all the vertebrae that contain the spinal cord segments involved in your anatomic diagnosis. For example, in a patient with signs referable to T3, L3 spinal cord segments, radiography should include T1 through the sacrum. Occasionally, practitioners are focused on intervertebral disc disease and only radiograph the vertebral column as far cranial as T10. Imagine if this had been done for Spanky in video 10-3. The T5, T6 vertebral luxation would have been overlooked. For many years, myelography was the gold standard for confirming the diagnosis and for surgical intervention. Now, fortunately, myelography is being rapidly replaced by MRI because of its accuracy and the absence of any need to access the subarachnoid space to inject contrast solution. MRI allows the surgeon to determine accurately the predominant site of the intervertebral disc extrusion and the precise location of the spinal cord edema. Unlike myelography, given our advancements in veterinary medicine, a definitive diagnosis of intervertebral disc extrusion protrusion should not be based solely on radiography because many dogs with other diseases have dense of intervertebral disc degeneration on radiography. At least myelography or CT and preferably MRI are necessary. When Sassy, the dog in this case example, was studied, only radiography was performed as advanced imaging was not available. This revealed a significant extrusion of the intervertebral disc between the L3 and L4 vertebrae. The owners elected euthanasia rather than surgery, and the diagnosis was confirmed at autopsy. Figures 10-18 through 10-20. Video 10-15 shows Mojo, a 7-month-old castrated male English bulldog that the owners thought had not been walking well on his pelvic limbs for nearly 2 months, and the problem was slowly getting worse. Study the video first. You should have appreciated the mild symmetric, grade 3 to 4, spastic paraparesis and pelvic limb ataxia and made the anatomic diagnosis of a focal or diffuse lesion between the T3 and L3 spinal cord segments. This alone should generate a differential diagnosis similar to that in Cassidy, the young Labrador Retriever in case example 10-5. However, you should have observed on the video that in Mojo, an abnormal dorsal curvature of the mid-thoracic vertebral column was palpated on the video. When you do this palpation, note the abnormal dorsal position of the ribs as they articulate with the vertebrae involved in the kyphosis. This strongly suggests a presumptive diagnosis of a vertebral column malformation with kyphosis and spinal cord compression at that level. This was confirmed with radiography and myelography. See video 10-15. That showed significant spinal cord compression over the elevated 9th thoracic vertebra. At the time of this study, no reports of successful surgical decompression of a vertebral malformation similar to this had been published. Since that time, several surgical techniques for the treatment of vertebral malformations have been described. However, given the technical expertise necessary to accomplish this, only experienced surgeons should attempt these procedures. It requires correction of the kyphosis by removal of the elevated vertebral bodies, which is a ventral form of decompression and an onerous task. This was done for Mojo in a 7-hour-long vertebrectomy procedure, in which the entire 9th thoracic vertebra was removed. Mojo was worse immediately after surgery as can be seen on the video, but over the following weeks, he recovered nearly all of his pelvic limb function and was still doing well 2 years after the surgery. Recall that it is believed that the delay in the onset of clinical signs in dogs with this thoracic vertebral malformation occurs because as the dog grows, kyphosis develops at the site of the malformed vertebral bodies. In time, the kyphosis causes compressive myelopathy in the spinal cord at this site. Remember that spinal cord malformations cause clinical signs to be observed at birth or as soon as the animal is able to walk, and they do not progress. Although the literature suggests that this disorder is more common in the brachycephalic breeds, any breed may be affected. See the description of this disorder following the differential diagnosis for case example 10-5. Video 10-16 shows an 8-month-old beagle from a research laboratory. The dog has progressive spastic paraparesis and pelvic limb ataxia caused by this vertebral malformation. Note the visible elevation of the malformed mid-thoracic vertebrae. Figure 10-21 shows the thoracic vertebral radiograph of this dog. The vertebral malformation has often been referred to as a hemivertebral, but in reality, it is a much more complex vertebral malformation. Case example 10-7 Signalment. 1-year-old female domestic short-hair chief complained. Abnormal use of the pelvic limbs history. Over a 2 to 3 day period, this cat rapidly lost the use of its pelvic limbs to the point that it could not stand without help. Examination. Video 10-17 shows the grade 2 spastic paraparesis and pelvic limb ataxia. Anatomic diagnosis. Focal or diffuse lesion between the T3 and L3 spinal cord segments. Differential diagnosis. Lymphoma. Feline infectious peritonitis. FIP. Viral myelitis. Protosomal myelitis. Vertebral malformation. Vertebral disc extrusion protrusion. Discus spondylitis. Degenerative myelopathy. The most common clinical disorders to cause progressive clinical signs with this anatomic diagnosis at this age are lymphoma and FIP viral myelitis. Usually, FIP infection causes multifocal signs or primarily caudal brainstem signs. Focal thoracolumbar spinal cord signs are unusual. Similarly, the less common protosomal infection by T. gondii usually causes multifocal clinical signs. Vertebral malformation is uncommon in cats and was not palpated in this cat. Clinical signs of an intervertebral disc extrusion protrusion are uncommon and usually occur in older cats, especially in the lumbar region. The same applies to degenerative myelopathy, which is even less common in cats. Discus spondylitis is rare in cats and usually causes extreme discomfort. Other neoplasms would be uncommon at this age. Myelography or MRI is needed to further support the diagnosis of a lymphoma, and CSF is usually very altered in cats with FIP and contains high levels of both protein and leukocytes. No ancillary studies were done in this cat, and she was euthanized. Necropsy confirmed an extradural lymphoma in the vertebral canal from the T5 to T7 vertebrae, compressing the spinal cord. Figure 10-22. Lymphoma is the most common neoplasm to affect the spinal cord in cats and cattle. It is usually located in an extradural position at any level of the vertebral canal but most commonly in the thoracolumbar region. Most lymphomas are restricted to the vertebral foramen of 1 to 3 vertebrae. Be aware that the color of the lymphoma may vary from a red to pale yellow in appearance. The latter form is easily confused with the normal epidural fat that is located in this extradural space. Most of these cats do not have evidence of lymphoma in other body sites except for the bone marrow and the kidneys. In our experience, most, but not all, have serum antibodies for the FeLV. Bone marrow and kidney involvement have been most commonly observed in cats that are positive for FeLV. Because of the possible systemic nature of this neoplasm, it is uncommon for these cats to have the vertebral canal lymphoma removed surgically. In my AD experience of studying the spinal cords of these cats microscopically, the lesions of compressive myelopathy are often quite mild, and clinical recovery or at least improvement would have been expected with surgical removal of the lymphoma. If surgery is done, it should be followed by chemotherapy and, in some cases, radiation therapy. Remember that occasionally lymphoma infiltrates nerves and mimics the clinical signs of a nerve sheath neoplasm. See case example 5-6 in chapter 5 and video 6-1 in chapter 6. This neoplasm may also develop in the intracranial leptomeninges and infiltrate the adjacent brain parenchyma. This is rare in cats and more common in horses. E.g., have also found lymphoma filling the ventral internal vertebral venous plexus in a 2-year-old cat, causing a significant compressive myelopathy of the overlying spinal cord. This patient had surgery followed by chemotherapy, and after 3 months, the signs recurred. Like other slow-growing extradural or intradural extraparenchymal neoplasms, the spinal cord has usually become significantly compressed before clinical signs occur. We believe that the onset of clinical signs, which may be fairly rapid, is associated with the time when spinal cord autoregulation to maintain normal blood perfusion becomes inadequate. Be aware that occasionally, after ancillary diagnostic procedures that require general anesthesia, the clinical signs may be worse. This may be caused by the effect of the anesthesia on the blood flow to this already compromised area in the spinal cord. Case example 10-8 Signalment. An 8-year-old castrated male German Shepherd dog, Sparky Chief complained. Difficulty walking with the pelvic limbs history. The pelvic limb dysfunction had been slowly progressing for about 5 months. His walking was better on some days than others. Examination. Video 10-18. Be aware that German Shepherd dog breeders have selected for a sloped back posture that results in increased flexion of the tarsus, which mimics tibial nerve paresis. In this dog, Sparky, that posture is normal. Anatomic diagnosis. Focal or diffuse spinal cord lesion between the T3 and L3 segments. We often refer to this gait as a T3, L3 gait, indicating loss of function of both the UMN and GP systems that control the pelvic limbs. Differential diagnosis. The following are all possible causes of a progressive T3, L3 lesion: degenerative myelopathy, intervertebral disc extrusion protrusion, neoplasm, discus spondylitis, myelitis, subarachnoid diverticulum, meningeal fibrosis, DJD of thoracolumbar articular processes, degenerative myelopathy. Degenerative myelopathy is the most presumptive clinical diagnosis based on the information presented here. A chronic intervertebral disc protrusion is the major disorder to be excluded. A prolonged slow progression of a spastic paraparesis and pelvic limb ataxia that is not accompanied by pain in a German Shepherd dog over 5 years old is degenerative myelopathy until proven otherwise. This is a diagnosis of exclusion because, unlike the other disorders in the differential diagnosis, no ancillary procedure is available to confirm degenerative myelopathy. The name degenerative myelopathy is redundant because, by strict definition, myelopathy is spinal cord degeneration. It is also very non-specific because many different myelopathies may occur in dogs, and many of them are inherited disorders. Nevertheless, neurologists use the name degenerative myelopathy as if it represented a specific clinical disease that is not only most common in the German Shepherd dog breed but also occurs in other breeds, especially the Boxer, Cuvas, and Bernese Mountain Dog. In our experience, this term refers to a disorder of dogs older than 5 years, in which a diffuse axonal necrosis is present primarily in the lateral and ventral funiculi of the thoracolumbar spinal cord segments. Secondary demyelination and astrogliosis are associated with this axonopathy. There is no pattern to this axonopathy to suggest a dying back process. Figures 10-23 through 10-26. Despite the presence of some neuronal cell body degeneration in a few brainstem nuclei, this is insufficient to explain the degree and location of the axonopathy. A genetic predisposition to the development of this lesion may exist, but the late onset and the lack of confirming pathologic diagnosis has made it difficult to establish that. The initial clinical signs of spinal cord dysfunction are commonly mistaken for the clinical signs of hip dysplasia, which may also be present in a patient with this spinal cord disorder. Occasionally, mild asymmetry exists in the pelvic limb signs, although the abnormal gait clearly exhibits the clinical signs of loss of function of the UMN and GP systems. In a small percentage, 10% to 20%, of these patients, you may find a unilateral or bilateral decrease decrease or loss of the patellar reflex, in the presence of normal or increased pelvic limb tone and no atrophy of the quadriceps femoris muscle. This patellar reflex loss is thought to represent dysfunction of the sensory component of the reflex arc. How it relates to the spinal cord axonopathy that is present in this disorder is unknown. It may be part of that process and reflect lesions in the dorsal gray column of the L4 and L5 spinal cord segments that are difficult to recognize. It may relate to the mild neuropathy in the dorsal roots that is commonly observed in autopsies of older dogs that have no neurologic signs or other lesions in the nervous system. This age-related neuropathy is most prominent in the roots of the lumbosacral spinal cord segments. Recall that occasionally the patellar reflex is depressed or absent in older dogs that have no other neurologic signs. In this spinal cord disorder, lesions of axonopathy are common in the cervical spinal cord segments, but it is very rare to see any neurologic signs in the thoracic limbs. The rate of progression of this axonopathy is variable. It may take 6 to 12 months before the dog is unable to stand without assistance. We have never examined a dog that had this diagnosis confirmed at autopsy progress to paraplegia. Owners are anxious to know how long it will be until their dog is unable to get up, and the question is difficult to answer because of the variation among individual patients. A number of studies have implicated disorders in the immune system of these dogs, but any relationship to the pathology of this degenerative myelopathy is unproven. This is not an inflammatory disease of the spinal cord. Attempts to identify evidence of a retrovirus in the lesions have been unsuccessful. No treatment exists for neurons with degeneration of their axons. Because this is a very slow degeneration, the patient may have brief periods of compensation that are thought by owners to represent improvement. Treatment of these patients with the anti-inflammatory drug imidacloprolic acid has been extensive because of the unfounded publicity it has received, but no scientific evidence exists to support its therapeutic or preventive efficacy. With the advent of alternative therapies and the desperation of the owners of these patients, many treatments have been tried, including acupuncture and chiropractic therapy. Evidence-based medicine does not support the use of any of these therapies. Fortunately, most of them have not harmed the patients. Vitamins E and B12 are frequently used because of their role in other degenerative neurologic disorders in domestic animals and primates, but no studies have established either a deficiency in these vitamins or any response to treatment. Treatment of a group of affected German Shepherd dogs for a period of 3 years with the nutraceutical S-adenosylmethionine, because of its role as a methyl donor in maintaining CNS myelin and axons, was not beneficial. Recent studies support the use of intense physiotherapy and prolonging the length of time the patient remains ambulatory. This involves primarily active exercise, with 5 to 10 minutes of walking at least 5 times daily, as well as passive exercise, massage, and hydrotherapy. In our experience, physiotherapy certainly does not harm these patients and may be beneficial for concurrent orthopedic conditions. Degenerative myelopathy is uncommon in small dog breeds and in cats. When cats have chronic degenerative myelopathy, felvantogen has been found in the spinal cord lesions. A similar myelopathy has been reported in 2 young German Shepherd dogs, but its relationship to the older dog myelopathy is unknown. The Pembroke Welsh Corgi is a breed that has been reported to develop a slowly progressive pelvic limb paresis and ataxia without any abnormalities on MRI studies. This may be a similar disease to the degenerative myelopathy described above, but with more continuous, bilaterally symmetrical, and well-defined spinal cord lesions. In a study of 21 affected Pembroke Welsh Corgis, the median age of onset of paraparesis and pelvic limb ataxia was 11 years. Progression of clinical signs occurred slowly over a median period of 19 months with a median age of euthanasia of 13 years. By the time of euthanasia, many dogs exhibited thoracic limb neurologic abnormalities and were paraplegic. A familial basis was proposed but not proven. Extensive studies at the University of Missouri have recognized that after many months to years of slow progression of what we have been calling degenerative myelopathy, the clinical signs progress from a UMN, GP quality to an LMN quality in the pelvic limbs leading to paraplegia. In addition, over time, thoracic limb signs are recognized with a similar progression in severity and quality that results in LMN tetraplegia. These investigators have classified their cases into 4 stages based on the progress of the clinical signs. 1. Ambulatory pelvic limb UMN paresis and GP ataxia. 2. Non-ambulatory paraparesis and GP ataxia to paraplegia with reflection in the pelvic limbs, mild muscle atrophy and some incontinence. 3. LMN paraplegia with thoracic limb paresis and ataxia. 4. LMN tetraplegia, severe atrophy, dysphagia, and tongue paresis. These progressive signs and lesions have been recognized in the German Shepherd dog, Pembroke Welsh Corgi, Chesapeake Bay Retriever, and Rhodesian Ridgeback. In these dogs with LMN paresis or paralysis, a neuropathy has been observed in the PNS, primarily affecting spinal nerves but also a few cranial nerves. Prior to these studies, the neuropathy seen in older dogs with or without the lesions of degenerative myelopathy were considered to be age-related and not directly related to the progressive degenerative myelopathy. In my experience with autopsies on dogs with degenerative myelopathy, the spinal cord degenerative lesions, myelopathy, far exceeded those in the nerve roots, radiculopathy. However, I have never examined a dog exhibiting LMN signs or one with any thoracic limb signs with this disease process. During my career, I did observe some degenerative lesions in the cervical spinal cord white matter without related clinical signs and could not explain this paradox. However, my observations were based primarily on dogs with a duration of clinical signs of 1 year or less. Those studied at the University of Missouri had exhibited clinical signs for a number of years. The investigators at the University of Missouri have proposed the term multiple system central and peripheral axonopathy for the CNS disorder, recognizing the nerve lesions and the LMN signs as a component of this degenerative process. Genetic studies at the University of Missouri have recognized a missense mutation in the gene for the protein enzyme superoxide dismutase 1, SOD1, in their studies of the breeds with this diagnosis. This intrinsic antioxidant is responsible for converting the toxic oxygen radical, a product of oxidative metabolism, to hydrogen peroxide, H2O2, and oxygen, O2. A similar mutation is considered a cause of the familial form of amyotrophic lateral sclerosis, ALS, also known as Lou Gehrig disease, in humans. The term amyotrophy refers to the muscle atrophy that occurs secondary to the primary degeneration of LMN cell bodies in the ventral gray columns that innervate the affected muscle cells. The term lateral sclerosis refers to the result of degeneration of cell bodies in the motor cortex of the cerebrum whose axons comprise the lateral corticospinal tracts in the spinal cord. In this human disorder, the most prominent lesion is the degeneration of the neuronal cell body of the LMN in the spinal cord ventral gray column. The nerve degeneration is secondary. At this time, such a primary cell body degeneration has not been reported in studies of dogs with this multi-system central and peripheral axonopathy. In addition, the myelopathic lesion affects multiple tracts in the spinal cord white matter and is not limited to the lateral corticospinal tracts, which are less well developed in domestic animals. See Chapter 5 for the discussion on equine motor neuron disease and see figures 5-14 and 5-15 for the primary cell body degeneration that relates to the clinical signs. This is a lesion that is observed in ALS in humans and is not a component of the lesions described for this multi-system canine disorder. These superb absorbed studies clearly support considering the entity referred to as degenerative myelopathy as a multi-system central and peripheral axonopathy, as well as its genetic relationship to a missense mutation in the SOD1 gene. However, it does not appear to provide a model for the human ALS disorder. The Orthopedic Foundation for Animals, OFA, provides a genetic analysis of a blood sample to determine the presence of the gene responsible for the missense mutation of SOD1. However, a normal dog with 2 copies of the mutated gene, homozygous, may not develop this disorder. Multiple mutations in the SOD1 gene have been identified in humans with familial ALS, and already a different mutation has been found in a Bernese Mountain dog with this diagnosis. In this case, the test submitted through the OFA was negative. The mutation was found through further investigations. In the near future, we can expect rapid advances in our understanding of the genetic basis for this disorder. Intervertebral disc extrusion protrusion certainly is the most significant clinical disorder that one must differentiate from degenerative myelopathy despite the slow and prolonged progression of clinical signs. Slow development of a bulging or thick and annulus fibrosis protrusion or the continued proliferation that occurs in extruded degenerate nucleus pulposus could cause this chronic compression. The diagnosis can readily be confirmed by imaging studies. MRI is, by far, the most reliable of these procedures. Be aware that it is common for these older German Shepherd dogs that develop degenerative myelopathy also to have one or more mild intervertebral disc protrusions. The experienced clinician recognizes this and avoids unnecessary surgery. In addition, a corticosteroid treatment trial may help to distinguish clinically significant intervertebral disc problems, as most dogs with intervertebral disc problems respond while dogs with degenerative myelopathy do not. Neoplasms typically cause progressive clinical signs, but the duration of the slow progression observed in Sparky is unusual. In fact, neoplasms that affect the spinal cord more often cause rapid onset and progression of clinical signs, as seen in Cassidy in case example 10-5. Nevertheless, neoplasia has to be considered a serious possibility. Examples of it include intramedullary glioma, intradural extraparenchymal meningioma or nerve sheath neoplasm, and extradural lymphoma or metastatic neoplasm, which may also affect the vertebral body, as in hemangiosarcoma. The diagnosis requires imaging studies. Disc spondylitis would not be expected to cause such a prolonged, progressive course and would be expected to cause significant discomfort in the dog. Myelitis would not be expected to remain so focal for such a length of time. Subarachnoid diverticula have been reported incorrectly as subarachnoid cysts that cause spinal cord compression in dogs. These are not cysts. They do not have an epithelial lining and are not an enclosed space. Although they have the appearance of cysts on myelography and MRI, the spaces readily fill with contrast during myelography or exhibit flow commensurate with that in the subarachnoid space on MRI, which supports the idea that they are diverticuli of the subarachnoid space. No basis exists for continuing to refer to them as cysts, which is a misnomer. The cause of the diverticulum is unknown. It may be the result of a partial obstruction of the smooth pulsatile flow of CSF. This may be caused by fibrosis of the arachnoid trabeculae similar to the lesion that is common at the C2, C3 articulation and is referred to as meningeal fibrosis. The latter is described in case example 10-14, with cervical spinal cord disorders. It is difficult to prove on microscopic examination of the meninges that are removed surgically to decompress the spinal cord. These biopsies consist of normal connective tissue. It is difficult to determine whether the connective tissue is excessive or not. We assume this connective tissue is derived from arachnoid trabeculae. These diverticula may occur at any level of the spinal cord but commonly are found in the thoracolumbar area. The onset of clinical signs varies from a few months to more than 5 years, and you would not expect the progression to be as slow as it is in this case example. The diagnosis is readily made by myelography or MRI. Degenerative joint disease, DJD, in the synovial joints of thoracolum. Bar vertebrae is commonly observed on radiography performed in older dogs but rarely causes spinal cord compression except at the lumbosacral articulation, where it may be a component involved with the compression of the spinal nerve roots at that level. This was described as the lumbosacral syndrome in Chapter 5. However, in young Shiloh Shepherd dogs, a DJD in one or more pair of intervertebral synovial joints occurs between the T11 and L2 articulations, which may bilaterally compress the dorsolateral aspect of the spinal cord. Clinical signs of spastic paraparesis and pelvic limb ataxia occur before 1 year of age, usually at a few months of age, and are progressive. The consistent location of this DJD at the thoracolumbar junction of young rapidly growing dogs suggests that at a critical time in their growth, an injury occurs to these joints and results in their malarticulation and subsequent DJD. The proliferation of the articular processes and their joint capsules may encroach far enough into the vertebral canal to compress the spinal cord segments located at these sites. The Shiloh Shepherd dog breed was developed from lines of German Shepherd dogs that were selected for their superior size and good disposition. These dogs have exceptionally long trunks. It is our hypothesis that during vigorous exercise and play, the long thoracolumbar vertebral column is at risk for injury at the thoracolumbar junction where less support and more mobility are present at the level where the ribs abruptly end. Histologic study of the affected joint shows only the changes expected with DJD. In reviewing radiographs of normal littermates of affected Shiloh Shepherd dogs, this lesion was occasionally seen without evidence of any spinal cord compression. The data collected at this time support the theory of an inherited predisposition for the disorder. Sparky was not a Shiloh Shepherd dog, and the onset of his clinical signs occurred much later than would be expected for the Shiloh Shepherd dog disorder. Radiography and myelography were normal in Sparky, as was the evaluation of his CSF. At the time of that study, MRI was not available. In our experience, MRI studies in dogs with degenerative myelopathy are normal. Based on these studies, a presumptive diagnosis of degenerative myelopathy was made. No medical therapy was advised. Physical therapy and as much reasonable exercise as possible were recommended. For other examples of degenerative myelopathy, consider the following videos. Video 10-19 shows Killian, an 8-year-old castrated male boxer with a history of several months of a slowly progressive difficulty using his pelvic limbs. Note the exacerbation of the gait abnormality when Killian is turning as he walks. Note the bilateral hypertonia but depressed left patellar reflex. Video 10-20 shows Macduff, an 11-year-old male collie with a history of 6 to 8 months of slowly progressive difficulty using his pelvic limbs. Note the absent left patellar reflex but normal tone and no atrophy in that limb. Video 10-21 shows Warig, a 9-year-old spayed female Dalmatian that had exhibited a slowly progressive abnormal pelvic limb gait for 8 months. Warig exhibits the classic appearance of grade 3 spastic paraparesis and pelvic limb ataxia. Case example 10-9 signalment. An 8-month-old female Afghan hound. Lewis. Chief complaint: inability to use the pelvic limbs. History: Lewis was one of 3 dogs in a litter of 6 that had developed similar clinical neurologic signs within a period of about 10 days. At 7 months of age, the entire litter was ill with fever, vomiting, and diarrhea over a 2-week period. They recovered from this illness before the neurologic signs began in 3 of the dogs. Examination. Video 10-22 shows severe grade 2 spastic paraparesis and pelvic limb ataxia. Note especially the inability to stand up on its thoracic limbs unassisted. Note how the trunk sways to the side as Lewis attempts to stand. When assisted, note the tendency of the trunk to sway to either side, yet note the normal thoracic limb gait. Anatomic diagnosis: focal or diffuse lesion between the T3 and L3 spinal cord segments. If this is a focal lesion, then it is likely to be in the more cranial thoracic segments. The difficulty in standing up on the thoracic limbs and the swaying of the trunk are caused by loss of the UMN and GP systems in the cranial thoracic region that normally control the axial trunk muscles. This is not seen when the lesions that involve the UMN and GP systems are located more caudally in the thoracic or in the cranial lumbar spinal cord segments. Differential diagnosis: the differential diagnosis is the same as described in the earlier cases of progressive signs of a lesion between the T3 and L3 spinal cord segments. The greatest concern at this age, and with the involvement of multiple dogs in the same litter, in which some undefined systemic illness has recently occurred, is the involvement of the CNS with canine distemper virus infection. The fact that all 3 dogs had the same spinal cord anatomic diagnosis is unusual. This viral infection usually affects multiple levels of the CNS, especially the brain. Multifocal clinical signs would also be expected of other infectious diseases such as toxoplasmosis, neosporosis, and rickettsial diseases. Remember that before you complete your list of differential diagnoses, you must consider the possibility of inherited degenerative disorders that might explain the anatomic diagnosis in this breed. This is especially indicated when multiple dogs in a litter are affected by the same neurologic signs. A description of just such a disease in the Afghan hound follows. Afghan hound myelinolysis. Afghan hound myelinolytic encephalomyelopathy is inherited as an autosomal recessive gene disorder. It is a unique primary demyelination that causes necrosis of myelin but spares the axons. It appears to start in the myelin in the mid-thoracic spinal cord segments and to progress cranially and caudally. The clinical signs begin with mild pelvic limb spastic paresis and ataxia and loss of control of the trunk muscles by 7 to 10 days. They are followed by thoracic limb spastic paresis and ataxia and then recumbency by about 14 to 21 days. The initial onset of clinical signs ranges between 3 and 13 months of age. The myelinolytic lesion is bilaterally symmetric in all of the funiculi but spares the fasciculus proprius. The naked demyelinated axons float unsupported in their funiculi among a plethora of lipid-filled macrophages. Figures 10-27 through 10-30. One of the earliest publications on this disorder erroneously explained this lesion as a vascular compromise. You cannot cause a primary demyelination with axonal sparing by means of any known vascular disorder. The unique distribution of this lesion is unexplained. Most of these dogs also have the same primary demyelination of the axons that surround the dorsal nucleus of the trapezoid body. No clinical signs have been associated with the lesion. This inherited myelinolytic disorder was confirmed at autopsy in the dogs in this litter. MRI studies of these dogs have not been described. Spondylosis deformans and dural ossification. These are 2 disorders anatomically associated with the spinal cord that are occasionally considered the cause of neurologic signs. It is our opinion that this association is incorrect. Spondylosis deformans is common in the thoracolumbar vertebral column, especially in older large breed dogs. Occasionally, it is seen in young adult dogs. It is most common at the level of the thoracolumbar and lumbosacral articulations. It is a proliferation of bone on the ventral and lateral aspects of the vertebral bodies, generally at the metaphyseal region of vertebrae on each side of the intervertebral disc. An increased incidence of intervertebral disc degeneration is associated with this spondylosis, but the spondylosis lesion does not extend into the vertebral canal and rarely reaches the level of the intervertebral foramina. This common disorder may cause some stiffness in the trunk and occasional discomfort but not paresis and ataxia. In well-developed cases, the bony proliferation may fuse ventral to the intervertebral disc, forming a bridge between the 2 vertebral bodies. An extreme but rare example of this vertebral body bridging is referred to as disseminated idiopathic skeletal hyperostosis, DISH. It is unclear whether spondylosis and DISH are a continuum or 2 separate diseases. Dogs with DISH have a continuous thick column of bone covering the ventral and lateral sides of the vertebral bodies in the lumbar and a portion of the thoracic vertebral column. E.g., diagnosed DISH lesion in a 9-year-old female babirusa, a wild pig species from Southeast Asia, which had spastic paraparesis and pelvic limb ataxia caused by an associated intervertebral disc extrusion. We believe that a fracture in the lumbar portion of the DISH lesion in this babirusa acted as a fulcrum at an intervertebral disc and resulted in its extrusion. Dural ossification involves the formation of plaques of bone within the dura that may indent the adjacent spinal cord. This dural ossification is a form of metaplasia of the dura. The plaques contain bone marrow. In the older literature, the plaques were incorrectly referred to as pachymeningitis. They are most common on the ventral midline of the dura in the cranial, cervical and lumbar areas of the spinal cord. Figure 10-31 shows an extreme example of this in a 6-year-old Great Dane in which the dural ossification extended the entire length of the spinal cord. The small indentations of the spinal cord caused by these plaques did not result in any recognizable microscopic lesions, so this dural ossification should not be expected to cause any neurologic signs. Occasionally, these plaques may be recognized on lateral radiographs of the vertebral column as thin, hyperdense lines where they cross an intervertebral foramen. Likewise, they are easily seen on CT and also MRI.